Okay, thank you very much.
Prof. Sulfas, good afternoon, Prof. Sulfas. Are you
Oh yeah,
already in the room?
yeah, yeah, yeah,
Hello, Prof.
yeah, yeah.
Sulfas.
For I don't know.
Can you hear me? Prof. Sulfas told
Yeah?
me that we will for his session because he is doing his hepatobiliary surgery at the moment, but he will join very soon and then will deliver his presentation. Prof. Paul Tahalele, are you already in the room? We will start very soon. Prof. Paul
I have
Tahalele.
problem. Yes, I have problem with internet. Wait a moment.
Oh, okay. So
It's clear.
yes,
My son,
yeah, your voice is
voice.
clear, but I did.
Um, no, I send my
Can you
PowerPoint
unmute your
to
audio, please?
the committee.
Because it's the evening EM in Chicago.
Professor Talhalehi, can you hear me? Hello? Professor Talhalehi?
Prof. Paul Tahalili.
Yes, Professor Talhalehi, this is Max.
Okay, maybe I will. Prof. Hendy Hendarto, are you already in the room?
Yes, I'm ready.
Okay. Uh, good morning, good afternoon, and good evening to all participants, and welcome to this fifth surgical forum of the International College of Surgeons Indonesia section. My name is Peter Johannes Manopo, MD, General Surgeon, FICS, as the coordinator and the moderator of this surgical forum. First of all, on behalf of the International College of Surgeon Indonesia section, I would like to express gratitude and to appreciate highly for all participants, particularly to the guest speaker, Professor Georgios Soulfas, MD, PhD, FICS from Greece, and Mr. Max Downham, the World Executive Officer of the International College of Surgeons from Chicago, United States. Also, the other speaker, to the Indonesia section president, Professor Paul Tahalili, PhD, FICS, and then Professor Hendy Hendarto, PhD, FICS, obtained as the scientific vice president of the Indonesia section, and Professor Sri Malyawan, the elect president of the Indonesian section, and the other speaker is Professor Samsu Budiono, FICS, ophthalmic surgeon from the Indonesia section, Dr. Franz Arifin, digestive surgeon, the secretary of the Indonesia section, and Mr. Bimo Gumlar and Ms. Dewi as the IT management of this surgical forum. So the first opportunity of this opening session, I would like to invite Professor Paul Tahalele to deliver his opening speech. Prof. Paul Tahalele, the floor is yours. Okay, I will skip. Maybe there is internet instability. I will skip to Professor Hendy Hendarto for delivering the scientific note. Prof. Hendy Hendarto, the floor is yours.
Thank you, Dr. Peter. Good evening, everybody. Welcome and thank you for joining webinar Surgical Forum Chapter 5, the International College of Surgeons Indonesian section. I would like to express my deepest gratitude and appreciation to Professor Paul Tahlili, Professor Sulfas, Mr. Max Dongham, Professor Samsu, Peter, and all webinar participants. The topic today is very interesting, I think. The adaptive surgery in new normal era. Ladies and gentlemen, all webinar participants, for the scientific note, I inform you that the new normal is a new state after the policy of stay at home, work from home, and social restriction program to prevent the massive spread of coronavirus pandemic. The new normal implemented with full awareness with the pandemic is still ongoing. For the reason, activity are permitted using established health protocol. So as a surgeon, we must be aware when planning operation. We need to adapt to the COVID pandemic situation. The important things is to make sure we're healthy, in a good condition, no comorbid, and if more than 50, better stay at home. And triage is the most important place to determine the condition of our patient, whether they are infected or not, before we carrying out the surgical procedure. If everything is safe and no problem, we can start the operation procedure using proper PPI. So I hope we all stay healthy and keep high spirit of working hard in this pandemic. And finally, thank you for the speaker for sharing the experience, and to all participants, have an interesting discussion. Thank you very much for the attention. Thank you.
Thank you, Professor Hendy, for your speech. For the next, I would like to invite Professor ready in the room, Prof. Paul
Yes, I'm there.
Tahlili.
Yes, okay.
Yes.
Yes, it's connect better.
Yeah.
Dibuka pintunya. Halo. Halo.
Deliver your speech at the moment. The floor is yours. Yeah. Please, Professor Paul.
Okay. Good days, everybody. Welcome to this seminar. Oh. If you hear my voice,
it's clear.
Peter, if you hear me,
It's clear, Professor.
Okay. Good day. Special for Honorable Professor Jordan Sulfas as a
you can proceed.
President of ICS Global, and Mr. Max Dongham as Executive Director of ICS Global. Welcome to this virtual seminar. And I would like to welcome Professor Hendy, Professor Sri Maliawan, Professor Samsu Budiono as speakers, and also ICS Indonesian Section Committee and all participants. Welcome to this International College of Surgeons Indonesian Section virtual seminar Forum Chapter 5. And first of all, Indonesian section of ICS has established in 1976 And the founders were Professor Sularto Rexoprojo, is an orthopedic surgeon. Professor Sehab Hilmi is also orthopedic surgeons, and Professor Putu Sukarno is also from Surabaya, is also orthopedic surgeons. And the other colleague, currently on passive members around 400, but active members only 120. We have several programs like humanitarian surgery, medical mission, visiting lectures, student general, donate personal protective equipment to the hospital in the rural area, research collaboration within university, giving health education on this, like this one is a virtual seminar continuously. I hope this next month we have another seminar, virtual seminar. Today we talk about COVID-19 pandemic, which had impact on changing our lifestyle, human behavior, economic collapses, and all activity becomes stagnant. I pray to the all participants be healthy and stay safe. Have a nice virtual seminar for all audience. Once again, thank you very much. Special for my friend, my president, ICS Global, Professor George Solfas, and Mr. Max Donham. Are you healthy? Are you ready? And thank you for participation for this seminar. Good days.
Thank you, Professor Portohleli, for your speech. And now I would like to invite Professor George Solfas, the world president of ICS. Professor Solfas, the floor is yours. Hello, Professor Solfas. Oh, I think he is doing surgery. I will skip to Mr. Max Downheim, the World Executive Officer of the International College of Surgeons from the head office, Chicago. Max, the floor is yours.
Thank you, Dr. Manopo. Can you hear me? Can
Yes,
you hear me?
clearly.
Okay. Thank you very much.
Yes.
You asked me to
Very
speak for
clear.
a couple of minutes, and so I'll try to stay within that time limit. First of all, to Professor Sufas, World President, Professor Paul Tahalehi, Dr. Arifin, Professor Hindarto, Professor Budiono, and to you, Dr. Manopo, all of the leadership of the Indonesian section. I think you are to all be commended for undertaking this effort of a series of webinars on the COVID-19 effects on surgery in various forms. So your leadership is commendable. It's fantastic. I think number two, you asked me to kind of chat about what's currently going on in the International College of Surgeons. As I indicated I think in the last chapter 4, the International College, I began by saying it's open to all races, creeds, philosophies, nationalities. We're apolitical. And so we're very proud of that. It's the founding philosophy of Dr. Max Thorak in 1935, roughly 85 years ago. We have 4 missions, and those are research, education, leadership, and communications. And they're all related. You just don't think about research or communications or education singly. They're all related. And this webinar series from Indonesia is a terrific example of the missions all being served by this program. I think in terms of things going on in the college, through the superb leadership of Professor Sufas, there are just a lot of things going on, and they're exciting. And just to mention a couple of these, Number one, earlier this week, we announced a specialty surgery webinar series that will go on a worldwide, regional, country, section basis, based upon the specialty surgical groups within the ICS. We'll begin those in September. And it's based upon, of course, the technology from telemedicine and the virtual platforms that are being used now because of the virus. So number one, that's fantastically exciting. And it is education, communication, leadership, the leadership of all of you and Professor Sufas being emphasized. The second thing that's going on or was announced this week is by Professor Sufas, the world president, is an abdominal surgery review course. We're inviting people to participate, to be involved in that review course. We've extended that invitation to the end of August, at which time then, beginning in September, under the leadership of Professor Sufas, we will undertake activities along that review course. And so, again, education and the other three missions being served by that activity. So both of those programs announced by Professor Sufas and myself, and the specialty surgery event by the chair of these specialty surgical groups, Dr. Fidel Ruiz-Healy in Mexico City. He's past world president and chair of the specialty surgical groups at this time. So those are exciting things going on. Number two, we all work for you. As I said last time in this webinar, number four, we work for you. And that means we want to know what you want from us, simply stated. And so we're doing a couple of surveys. One has been underway. We are about to close it out in 1 or 2 weeks. It's a membership survey, and it's designed to give us some insights into what the fellows in the college worldwide are feeling, what they're thinking, what they want. And the second survey that will be launched soon after, excuse me, soon after the membership survey is a survey on the official journal of the International College of Surgeons, which is International Surgery. We want to know what you think about that, how it can better serve you, and so forth. So we will communicate summary results of both those surveys. And I believe, Dr. Manopo, courtesy of you and the wonderful leadership of the Indonesian section, I probably have exceeded my 2 minutes that you gave me, but those are my remarks in terms of what's going on at the current time. Again, the college is an absolutely terrific organization, apolitical, open to all races, creeds, nationalities. It's an exciting organization where, amongst other things, enhanced by this program, for example, is the collegiality of and the relationship amongst all the fellows around the world. So, Dr. Manopo, thank you so much.
Thank you very much, Mr. Max Dunham, for your notes. And now we come possibly Professor Solfas. Are you already in the room? Hello, Professor Solfas.
Yes, hi. I'm here.
Hi. Yeah. Okay. I would like to invite you to deliver your opening speech for this fifth surgical forum. The floor is yours.
Great. Thank you very much. First of all, let me say what indeed a pleasure and an honor to be here today amongst you. And I want to thank and congratulate the leadership and the members of the Indonesian ICS section, not just for today, but for being throughout many, many years a very active and a vibrant section with global surgery. And for today being the first one to show the way for the future. They say that when life gives you lemons, make lemonade. And I think today is an example of the right way to respond to the crisis that we've been living during these last several months. Throughout the world, we've had the situation with COVID, and I know the hard work that everybody has put into their response. And a special challenge has been for scientific associations, because we don't have the luxury of having the meetings, we don't have the luxury of seeing each other in person necessarily, and that means that that's a setback for everything, for promoting our goals and our causes. However, in difficult situations, you have to find ways to respond, and this is a great example, this webinar. I see that we have over 130 participants, which is great, and I think is taking advantage of situation, taking advantage of technology to really have a discussion, have a conversation, discuss scientific issues, and make the presence of the ICS Indonesian section felt throughout not just the country, but globally. And I think really my heartfelt congratulations to the whole chapter for this initiative, for putting together a great program, but most of all for your commitment to the ICS throughout the years. I think the webinars, as Mr. Downham mentioned, will be one way that we can really help our fellows, and not just our fellows, any interested physicians, by giving them a platform for education, a platform for discussion, and it's really also a way to interact more across the globe. It may not always be easy to have a big meeting in one part of the globe with everybody from around the world going there, especially with a truly global organization like the ICS. But with Zoom, we can achieve that. We can achieve more participation and more active participation. So I think this is a great initiative. And again, thank you for the honor and the opportunity to share this with you. And
Thank you
hope,
very
and I'm
much.
sure there will be a tradition what starts today. Or thank you, Peter.
Thank you very much, Professor Solfas, for your opening speech. And the last opening session, Dr. Franz Arifin from the Indonesia section secretary would like to inquire about a brief survey about the surgery in Indonesia regarding of the COVID-19. Dr. Franz Arifin, the floor is yours. You have 10 minutes.
Thank you, Dr. Peter. Can everybody see the slides?
Yeah, not yet. The slide, not yet. Only your picture.
Oh, okay. Just a moment.
Your picture and your voice is clear. Yeah.
Yes, just a moment, Dr. Peter. Okay, is the slide on screen?
Yeah.
Okay.
Yes.
Thank you for the time. So I will present very short results of the survey that we do for the ICS members of Indonesian section about the impact of the COVID-19 to surgical service in Indonesia. So we have about 46 members who responded to our online survey. The survey duration is 3 weeks, and the method is an online form survey using Google Form. Our questions are these 5 problems. First, what is the perceived overall effect of the pandemic to the professional practice of our member? What is the perceived surgical system ability in coping with the pandemic? What are the personal practices, and how are the overall well-being of the members on the pandemics, and what are the impacts of the pandemics to the surgical services? So this is the result. So most of our respondents response that the magnitude of the pandemic impact to personal practice either very high or high. So this is about 80%, almost 80% of the respondents reply that the impact is very high or high. What are the impacts? Some of the impact that has the most replies are less patient and less consultation, less performing procedures or surgery. There are increased costs to the patient because of the preparations and of the screening procedures or protocols. And the protocols are perceived to be making a more difficult in doing surgery or in performing surgery, especially if you have to use a level 3 PPE for the surgery. This is how the respondent perceived to the surgical system. So most of the respondents are satisfied with the surgical system and the adaptations that was performed by the hospital. So about 70% are satisfied, which responds that the hospital system adaptation is satisfactory to excellent. The availability of PPE or personal protective equipments are quite good, because only about 15% mentioned that the availability of PPE is poor or fair. So I think it's quite good, because 70 to 80% are having availability of PPE. What about the protocols, availability of protocols and the implementation of protocols? As you can see in these slides, the availability of the protocols are satisfactory to very good, which is comprised to about 70% of the respondent, and the implementation is 80%. So I think overall the satisfaction about the availability and the implementation of the COVID-19 protocol in the hospitals are quite good. So we asked the respondents about their preparation, perception of preparation for the new normal. Now here we found out that about 20% are not satisfied to the preparation for the new normal. So either they are not ready, or they think that the condition are not proper for the new normal condition. But of course, the majority are already satisfied and mentioned that the preparations are very good, about 24%. For the personal practices, so we asked several questions to the respondent, and as you can see, most of the respondents always use the recommended PPE in doing the surgery or any procedures. But this does not match with the second questions, which most of the time, or mainly, that they provide their own PPE, which is not available in the hospital. So the second questions about how often that you have to provide your own PPE was answered. About 60% of the respondents says that they have to provide at least sometimes of the PPE themselves. In performing emergency procedures, they sometimes to rarely is the most common answer, and this is also the same for the consultation in the nightly resting hours. Almost all the respondents respond that that overall well-being is negatively affected by the COVID-19, and to the surgical services, this is also having a very big impact, because about 80% agrees or strongly agrees that the pandemic have negative impact to the surgical services. What are the negative impacts that was mentioned? First, there are high psychological stress of the transmission, fear of transmission, and general anxiety, less patient, less operation, higher cost, and less income. And the patient also experience fear of going to the hospital, and some are mentioning disrupted scientific schedule. These are the ways that the respondents mentioned on how can ICS contribute to the mitigation of the pandemic. First, ICS can provide or create a practical guidelines for the surgical services. Second, the ICS can update knowledge through seminars and contribute PPA as necessary. And of course, the last one is the ICS is expected to do an advocacy to related organizations to socialize the guidelines that they provide. So in conclusion, the ICS members mostly perceive negative impact of the pandemic to professional practice, personal well-being, and overall surgical services. However, many also perceive that the surgical services has resources, PPA or protocol that may mitigate the impact. Hospital readiness can be improved to provide facilities that can further reduce the negative impacts, such as providing on-site PPA so the surgeons don't have to bring their own, and improve the availability of protocols. Most of the respondents are perceived that they are ready for the new normal in surgery. So the last slide says we are very grateful for all the ICS members who participate in the survey, and we thank you for that. Thank you, Dr. Peter. That's all.
Thank you, Dr. Franz Arifin, for your inquiry about the brief survey of the International College of Surgeons. And now we come to the scientific session. For the first opportunity, I would like to invite Professor Georgios Sulfas from Greece as the president of the ICS Global, on the role of technology in hepatobiliary surgery adapting to the future. Professor Sulfas, the floor is yours.
Thank you very much, Peter. And let me put the presentation on. Okay.
Excuse me, you will run your slides by yourself, or the host will do it for you?
I can run them by myself.
Okay, fine.
Can everybody see okay?
Yeah.
Okay, good. So today what I would like to take this opportunity to talk to you about is the role of technology in hepatobiliary surgery and how we can use this to adapt to the future. There are no disclosures to make, and I would like to discuss what's really the situation with technology. I don't want to propose to you that technology is a solution to everything. And I don't also want to propose that surgery needs to be expensive, high tech, but I want to suggest that there are ways we can use technology in order to make our lives and our patients' lives better globally. And one of these technologies is 3D printing. So the first question is, how necessary is technology in hepatobiliary surgery? And there was a very interesting study showing that all these different techniques that exist for liver resection, whether it's the CUSA or whether it's using radio frequency, using ablation, cauterization, using microwaves, or just using the Kelly clamp. Which
I'm
one
sorry,
is better?
Professor Sulfas.
Yeah.
Your slide is not shown.
Okay.
Yeah.
Give me 1 second. Okay. How's this? Is this?
Yeah, perfect. Perfect.
Perfect.
Yeah.
Okay. Sorry.
Yeah.
still getting adjusted to the new technology. So, how necessary is technology? There are different ways for resection and in liver surgery. A lot of different techniques, different machines that are suggested. Using the CUSA, which is an ultrasonic aspirator, using radio frequency ablation, using microwave, um, all sorts of things, or using the simple, good old-fashioned Kelly clamp. Excuse me. And there was a very good study by the Cochrane Institute where they used randomized studies till 2008. And what they saw, which is very interesting, was that the scalpel technique using the clamp, very simple technique, essentially using the hands, was 2 to 6 times more economical, which is expected, but also was faster in the right experienced hands with decreased blood loss and without any increase in the complications. So essentially, what this means is that you cannot exchange experience with technology. Both are important and both are necessary. And there are certain types of technology which may be older, however, they're very, very useful. The hepatic artery pump has a very interesting story. It's used to deliver chemotherapy to usually metastatic lesions in the liver, and it's implanted in the abdominal wall, and the catheter goes directly into the hepatic artery. So the implantation is a surgery, but then it can stay there for many, many years, and you can use that to give the medication. Around the world right now, you will see it in very, very few places. And however, one of these places is Memorial Sloan Kettering, which is an excellent institution doing great work. So one has to wonder, why are we seeing the hepatic artery pump used there and not all around the world? It's the concept is a very good one. You give the medication directly to the lesions through the local vasculature, and you can give increased doses with fewer toxicities with excellent results. The problem is, and the reason that we don't end up using it as much, is because it's harder for the oncologists and for everybody to administer through the pump, watch the pump, make sure it's working okay, rather than give it peripherally. However, the results are better. Moving on to the 3D printing notion. This started from the creation of a team at our institution in Greece for the management of hepatic tumors. And the important thing is that this was a collaboration between the Department of Surgery, the Polytechnic School, with the Rural and Surveying Engineering department, one of our biggest university hospitals, and then a couple of private companies. And the whole idea in the protocol was that the patient would come with a CT scan or an MR to the radiology department and then this data would be transferred through an electronic platform, and the surveying engineering department from the Polytechnic School had created a program to transfer this data to the 3D printer. So this way we could go from a 2D to a 3D model. And you could end up with a model of the patient's liver, the specific tumor, the specific vasculature, printed in a one-to-one scale. So the research question was, once you have that, is it useful? Is it something that's going to change things? And we wanted to look at things in three different areas. Specifically, one was the education. Could it help us in training students, residents, and even attendings? Two, could it help us in giving and providing the patient with information? And three, could it help us during the surgery have a more safer procedure? So here you can see some of the methods used, basically digitizing the CT scan. You have to identify the area, which in the first case we had to do using the pointer for every slice. Then through the right program, this could be done by the program automatically to identify the liver and differentiate it from the surrounding structures. Following which, you went to the modeling part of the program. And what you did in the modeling is you started taking the data from the scan, creating the model of the liver. And these, again, are from the initial models that we had. And basically, you will see that you take all this data, you have the periphery of the liver, and then slowly you start filling in the thing. And it shows you the anatomy as well as where the mass is. To take you to the third part, which is printing. And this is a printer, this is not a liver being printed. This is from one of the other projects that they're using for skull, um, printing parts of the skull. And the printing itself can be an expensive process depending on if you want to print more using more colors. So the veins, arteries, different colors. That means you need more printing heads and more cost, a bigger machine. And it's something that takes hours in the best case scenario, and usually takes close to a day or sometimes even more. So it's a process. It's something that needs to be planned when it's being done. Now, one of the things that during the course we started doing better was using technology with an iPad. You could scan here, this is one of our partners from the surveying school. You could scan the organ, the mass, the tissue, and then you could send that information to the printer for the 3D printing. Why was this useful? Because when we had the tumor come out, we would scan the tumor with this iPad and then go ahead and do a 3D printing and compare the size of the actual lesion with the one that we had calculated. One of the ultimate goals in this is to move to bioprinting. And what is bioprinting? Instead of an regular ink or colors, what you use is cells, and you create something that has living tissue, living culture in it.
Excuse me, I cannot hear your voice, Professor Sulfas.
So the whole idea is the ink that you use in bioprinting is cell culture cells, now theoretically stem cells, for example, so that you could actually print something that has the ability to be alive, to be viable. Here you see some things that were printed. Some of these, especially with bones, can actually be used clinically. These were the first livers, the very, very first, which you can see are very a gross picture, not very detailed. And as we moved on, we're able to come up with the livers that had the patient size, had the actual tumor, you can see there, and you had the hepatic artery in red, you had the portal vein blue, and hepatic veins in purple. So we were able to go to more detail and come close to seeing the comparison between the actual and the printed one. Here we see a case with a big central mass in the liver that was between the left and right portal vein. And as you can turn this picture around, you can see exactly how close or far it is actually from the mass. And here was a central mass that I mentioned. You can see the picture, and this was the end result. So it really gives you, no matter how experienced you are looking at a CT or an MR, being able to see this in actual 3D size gives you a great idea of the exact location, the topography, the map of the mass. And one of the things that we want to do next is actually project the image into space. So project the 3D printed image into space and in the operating room. So you could actually, during the surgery, look at it. Oh. No, I guess. I'm sorry. Oh, let me see if it's. Give me 1 second. I apologize. I want to see if it's playing somewhere. Okay. So here, I hope you can see this. Can everybody see this?
No, sorry, we cannot see your video.
Okay.
Just the topic, 3D printing results, but
Okay.
not the video.
Okay. I apologize for that. Well, we'll move
It's
on.
okay.
So the objectives here were to see through a computer algorithm to transfer the CT scan and the MR images to the 3D printer for education, informing the family and consent, and plan the surgery better. And the key thing, one of the lessons we learned was the importance of interdisciplinary collaboration. There are great people out there who are not surgeons, who are not physicians, and who have knowledge that we can make good use of. And the next steps, and this was what I similar to what I would show, is basically you can project the image of the 3D printing into the actual operating room using either um, a tablet or using glasses like um, the Google glasses. And once you do that, you have the exact map right on top of the liver that you are using, and that can help you guide your surgery much better. So navigation technology in hepatobiliary surgery has the goal of being very targeted, knowing exactly where you're going to go, and thus avoiding losing more hepatic parenchyma and avoiding more blood loss. So a safer surgery. And things that have been useful are the intraoperative ultrasound using systems like MEVIS and Pathfinder. The ultrasound is basically, a third arm for the surgeon. Whether it's open or laparoscopic, it gives you an exact feel for where the masses are, where the vessels are. What the MEVIS system is, using the CT, it can give you a picture of where your mass is and the vessels that you're going to have to deal with over there. So this way you can make your strategy and say, this is going to be my plane. The Pathfinder is another object which is actually was very well advertised in the US, but it hasn't been used as much. And the idea is that you take the CT and upload it into the machine, and there you can see the mass and the 3D picture on top of it. So during the surgery, you can look at it, and using a scanner, essentially, you can point the scanner at the liver and know exactly where you are in relation to the mass. The argument against this is that this is something expensive, that it's not going to be able to take away the importance of the experienced surgeon. The experienced surgeon can pretty much find all these things just as well. And here you see again the idea of projecting the mass on top of the actual liver with the anatomy of the vessel. So you know where you are, you know what you want to do. This makes for a much more targeted experience. Now, as I mentioned, the ultimate goal is bioprinting. And the idea with bioprinting is that you can use the anatomy of 3D printing to help for liver transplants, for living donors, where you have to be very exact, for biliary surgical anatomy, to plan the surgery, as you can see here, with the mass in relation to the others. But there are several challenges. One of them is the cost. The other one is the material, that you need material that's similar to the tissues you use. You need coloring to differentiate between the two. And the size differences, especially when you're talking about blood vessels, where we're talking about, you know, less than a couple of millimeters, any change makes a difference. And of course, the key thing is the quality of the image, because that's what your final 3D printed product is based on. Now, what's the holy grail? It's basically bioprinting. And the idea behind it is if you can have the scaffold, the skeleton, add on it the bioink, which is cells or stem cells, then they can multiply, and essentially you can end up in a situation where you start having artificial tissues and maybe one day organs. Now, we're way, way, way behind that happening. However, the basics are potentially already exist. So you can see here some work with basic scaffolds and the cell cultures on top, and some cases where groups have actually been able to produce small amounts of tissue. Now, you cannot have too big a tissue because you're not going to have enough vascularity to continue with that. Now, there are several issues in terms of bioprinting and creating an organ, including the ethics, which is a very big one, and needing to have multiple layers to actually have a good result. Now, in terms of technology, there isn't only 3D printing, there are other ones. And the one that's really we keep talking about is artificial intelligence. Now, artificial intelligence is not something new. It's something that's been there since 1950s when it was first described. And it's the whole idea of machine learning and using algorithms to improve artificial neural networks. What's interesting, however, is that it has evolved and we're very close to seeing clinical applications. The whole idea is that the same way that we learn from seeing one, two, 10, 100 examples, the machine can learn from seeing not 100, not 1,000, not 1,000,000, see much, much bigger number. And then it can start learning from using the results from this data. So the essential thing for artificial intelligence is big data. Um, some cases where it was used clinically is radiology, where they compared 100 radiologists for digital mammogram to artificial intelligence, and they saw that the results were comparable. One application for hospitals was at New York Presbyterian, where what they did is they used the technologies from artificial intelligence and robotic process automation to help their flow of work in the emergency room and on several of the floors. So they could identify areas, something that Johns Hopkins did as well, having a central command station where they could identify which beds would likely be open in the next hours, when you would have a bed or an operating room available in the next hour. And this way you could move things seamlessly around the hospital and streamline the whole process using data that was coming in continuously. So, what are some of the issues? The first one is big data, meaning you need information. You need information to teach the machine how to decide, how to acknowledge things. But when we're talking about information, there are some issues. One, how are you going to obtain them? You don't need, for example, you're in a big city. You cannot take from one hospital. That's not enough. You need to take from all the hospitals. So that means that people need to cooperate. So that's your ingredients. How are you going to put them together is another question. Also, when we're talking about data, and especially personal data, safety and security are very important. Another one is the GDPR, which is what we have in Europe now. And basically, it has to do with not allowing personal information and having very strict rules. Also, the economy part. You saw that the hospitals, why do you think the hospitals would use artificial intelligence to streamline their operations? To make things much financially rewarding. And of course, when you hear that aspect, the next question is, are people going to lose their jobs? Is that where we're getting it? Is this like in the next industrial revolution? So are we going to assimilate or adapt? And the answer is we do not need, it doesn't mean necessarily that the human element goes away. It just means that you have to adapt, learn the technology, learn what it can offer you and do for you, and then find ways to use that, train your people in how to use the artificial intelligence and how to use this data that's available. So, in conclusion, talking about technology, some of the basic things that I can suggest, which are applicable to hepatobiliary surgery, but not just that. Number one, you need collaboration. Reach to other disciplines. See what the engineers, see what the computer scientists are doing. Talk to them. They would love to work with a surgeon. They would love to find clinical applications for their work. And this is something that it's a win-win situation. Number two, you have to evaluate technology well. It doesn't mean everything that's new, everything that's expensive, everything that's fancy doesn't mean that it's good, doesn't mean that it's going to make a worthy change to our lives and to our patients' lives. So we need to evaluate them in a strict manner and see what they're good for and whether that the cost of that is worth taking. Also, we have to remember technology for us surgeons, technology is not a substitute for proper technique. There are a lot of machines that we use in our everyday practice. Um, you have residents today who don't know how to do an open cholecystectomy or how to repair an open aneurysm or how to do a hand-sewn anastomosis, maybe. Uh, but we need to be aware that proper technique is more important, and also that technology is not available around the world. Which brings me to my last and most important point for us in the ICS, that technology is not about doing things in an expensive way. It's about promoting our goals to in a way that will reach many more people. What do I mean by that? For example, 3D printing. 3D printing has been used and can be used to help with healthcare in a global setting, help with healthcare in disadvantaged areas, as for example, you can print surgical instruments, or you can put clamps for births. You can do a lot of things that can actually help the people who are down there in the field and do that in a very cheap uh, and practical way. So technology does not necessarily mean expensive, does not necessarily mean fancy. It's something actually that if we learn to use correctly, we can help our goals of global surgery. Again, I would like to thank you for the opportunity to share this um, information with you. Thank you very much, Peter, and I'd really like to thank the whole Indonesian section for this opportunity.
Thank you very much, Professor Solvas, for your informative presentation. I would like to proceed with Professor. The next speaker will be Professor Samsu Budiono, ophthalmic surgeon from the Indonesia section. Professor Samsu Budiono will talk about cataract and refractive surgery. Professor Samsu, the floor is yours. Sorry, we cannot hear your voice, Professor Samsu.
Sorry. Just a minute. Okay. This.
Yeah.
Okay.
Okay.
You can hear. Okay. Yeah. Good evening, everybody. First, I will say that I'm honored to be invited as a speaker in this forum, as this is my first. Okay. In the evening, I choose cataract and refractive surgery. Can you open the slide? Because I I have sent all the PowerPoint.
Okay.
Yeah, maybe.
Okay. Mr. Bimo, please run the slide screen share for Professor Samsu. Professor Samsu, you just tell us next or back, okay? And then we will do it for you.
Yeah. Thank you. Okay.
Mr. Bimo, please run the Professor Samsu Budiono slides. Please allow some moment to prepare.
Yeah, no problem. Tadi nggak punya.
Mr. Bimo.
Sorry, I have also my own slide, but I don't know it is can operate in this forum. I don't know.
So you will run by yourself, or the host will do it for you?
Maybe if this take a long time, I will try to operate by myself. Okay.
Okay, you can do it
Yeah.
by yourself. Yeah. Thank you,
Okay.
Professor Samsu.
Thank you very much. Kayak non gini.
Kelihatan Pak. Ini.
Ya.
Dibuka terus harus share screen. Slide dulu Mas. Slide dulu.
Yeah, we can already see your slides.
Okay, bisa lihat ya.
Bisa lihat ya.
Okay, can you see my slide? No.
Yeah, clearly.
Okay, thank you. Kurang bawah. Bisa ya. That's a minute. Kurang buat begini. Tidak usah, tidak apa-apa. Oke. Ya, oke. Okay. I apologize for this. And I apologize also that there are some videos about eye operation and there are in my presentation. So if you don't want to see, maybe make fear or afraid, maybe please you can turn off the video for minutes. Okay, before going to present this cataract and refractive surgery, I will talk about the anatomy of the eye for reminding. Okay, so you can see here that the lens is located in the center of the eye behind the iris, and it divided all the chamber in the eye become two two part. The front and the lens of the lens is called anterior chamber, and the other is called posterior chamber. Okay. The lens is stable in this location because it's supported by suspension ligament, but the name is zonula sine completely. This you see here in this slide, the auricle of zonul is in the ciliary body, and the muscle of the ciliary muscle, good contraction and or relaxation, making the lens move, become concave and convex, and this is called accommodation process. So you see, besides focusing light on the retina, the lens also adjusts the eye focus, letting us see things clearly, both up close and far away, because the accommodation process is normal. So why I choose a cataract today, this evening? Because cataract is mostly causes of blindness all over the world. Of course, beside the glaucoma, retinal disease, or also maybe tumor and so on. That's the mostly of cataract. Normally, the lens is clear. Normally, the lens is clear, but gradually become cloudy and hazy, especially due to aging process. Okay. So you see here the picture. The picture is cataract. That's called cataract incipient because cataract is very the hazy is very not so thick. Sometimes it is not disturb the visual acuity, but it is gradually become cloudy and cloudy and cloudy, and it become make a disturbing of the visual acuity of the patient, and usually it is the mostly cataract patient is senile patient or old man or old woman. That's called immature senile cataract. If this cataract is located in the central cornea, it is of course disturb his vision, and it is gradually become entire the clouded and entire the sorry this later on the cloud fill up the area of the lens and called senile cataract mature senile cataract, and of course this patient couldn't see anything. If this condition does not taken care, that this cataract become hypermature and is very dangerous. Why? Because the sonol become weak and fragile, and that can drop to the posterior chamber. Okay, it is the same picture, I think, but you can see that too many type of cataract. So, how do we treat it? The only way is performed is surgery. Okay. Okay. Sorry. Okay, sorry. In era 1975 until 1940, this cataract extracted is much extracted directly. First, we make a open the area by using the sketch and then put the iris slowly and then put the this of extractor and then close, and then it because the wood is white, it is must suture with a nylon suture until 10 or 15 suture. Okay, next slide please. Okay. The patient who have no lens, that's called aphakic patient. So to help the patient of after operation done, the aphakic patient, the patient also only finger counting at 1 meter. So to help him, he must use a glasses. That's called aphakic glasses. This aphakic glasses, of course, is very thick because the lens have a reflection that's about 10 diopter. Okay, so this glass is also about 10 diopters. It is thick and heavy, can make discomfort, and look what like a parabola. It is discovered, and of course she doesn't like. Okay, the other choice for replacing the eyeglasses, the patient could wear a contact lens, but the contact lens is very difficult to wear because old man or old woman is very difficult, I think. And then also difficult to manage because it must be washed time by time. Okay, and sometimes become infection. Why? The cornea become hypoxia because closed by a contact lens, and it is easy to be infected. Another choice beside the eyeglasses or contact lens, we can we can we can insert the intraocular lens, that's called IOL, is intraocular lens. It means into the anterior chamber like this. Sorry, if it is okay. Okay. Yeah. The anterior chamber lens is setting the anterior incision with a small incision and then make an cloth, like you see in the above picture. And there's two types. First is intersection lens. That's all. It is long lens. It's created by professor in Holland. And the other one is angel fixated. It's on the setting lens. It's the most popular now. This phacoemulsification operation using an Plaza foldable intraocular lens. Okay, this is the video. Sorry. Yeah. Okay. So you see, we must make some incision with a cutter. It's the next port and second port. Yeah. But then we open the superior of the lenses. That's all. And take the capsule of the lens and the capsule of the lens using small or check the eye. Okay. After that, the nucleus of the lens. After
Excuse me, Professor Samsu, your voice is not clear.
and remove the segment one by one. One by one. Remove one by one. Then continue to clean the contact. Then we decide to follow the next. And this is something affordable and nice. No need to because I think it make astigmatism for the patient. It is make not comfort of classes. This is animation of sorry. Okay. This is step by step of operation. This is manual adaptation using configuration
We cannot hear the sound, your voice. For Samsu, it's not clear.
Please unmute your microphone.
Hello.
Yeah,
Everybody?
I can hear. Yes, perfect. Please be close to the microphone. Hello, Professor Samsu.
Okay. Do you hear me now?
Yeah, I can hear you now.
Okay, thank you. Sorry.
Yeah.
So the differentiation between laser cataract surgery and phacoemulsification is the first emulsification using instrument insert into the eye, and the laser cataract surgery, all doing even the make incision in the cornea and so on from the laser with laser. Okay, so the what's that? The incision is very small and smooth. Okay, I continue with next slide. Okay. After the operation, even using posterior chamber IOL, this only 4 sight away. Okay, for near sight, the patient must use reading glasses. So now we have other choice. That's called premium intraocular lens. This lens is can use for near, far, or intermediate way. Okay. This is a sample of the posterior chamber IOL. This is this standard. Okay. Oh, sorry. Yeah. This is standard IOL, and it is multifocal IOL. So it is for far, near, and intermediate sight. Okay. And toric IOL intraocular lens is one only for patients who have astigmatism. Okay. And the other is accommodative IOL. Here, okay, you see. Yeah. It can accommodate and see clearly even far, near and intermediate. Okay, this is about cataract, and I now change to refractive surgery. Refractive surgery mean this is non-essential eye surgery used to improve the refractive states of the eye and decrease or eliminated dependency on glasses or contact lenses. This is called LASIK. Okay, sorry. LASIK is LASIK is laser-assisted in situ keratomyolysis, and this operation done in the superficial of the cornea. First, make a corneal flapping by using even standard microscope or using femtosecond laser. After that, we do excimer laser, maybe not more than 1 minute, and then return, and then return the corneal flap and this finish. Sorry, this is standard LASIK. Sorry, this on the animation. Yeah, okay. So you see in the ear, the superficial cornea. Sorry. This is a microcratum, section 4 before doing, and then make a corneal flap using an excimer laser, and then after that, close the flap. Oh, sorry. The different with femtosecond is like this. This is femtosecond laser. Okay. Yeah. This is same technique, but it make the corneal flap. This is using laser, femtosecond laser, but use micro, and then the same technique open the flap after the action laser, the stumble frame. So after the second maybe not more than 1 minute between this and return the flap. Okay. Yeah, this is. But because make a corneal flap, it is a wide incision. Sometimes it is make a make a glare and so on. So now there is a new technology that's called SMILE laser eye surgery. SMILE, that means small incision lenticular extraction. You do like this. Okay. Okay. Make the same make a laser done in the part of the corner stroma, okay? Not doing flat, but they make a small incision. And like this, after that, without step, the channel, at the small channel, okay, that's a finish. It is more, it is easier, okay? So that is all about the cataract refractive surgery, and it is let's conclusion. But this what's that? It is like what we say. The smaller incision is the better vision. Okay, thank you very much.
Thank you, Professor Samsu Budiono, for your presentation. And now I would like to invite Professor Paul Tahalele to deliver the presentation on the adaptive surgery in the new normal era. Professor Paul Tahalele, the floor is yours.
Thank you, Peter. Do you hear my voice?
Yeah, clear, very clear.
Clear, yeah.
Yes. Also your slides, but not yet as full screen. Okay, already full screen.
Oh, yes.
Yeah, perfect. Already
Okay.
full screen. Yeah.
Yeah. Good days, Mr. Max and our president, Professor Zolfas from Greece. How are you? Everything going well, Professor Zolfas?
Professor Sulfas is asked for permission to go back to the operation room to do another surgery. Yeah.
Yeah, it's okay.
Yeah. Maybe later on.
This is my topic, adaptive surgery in COVID-19 entering the new normal era, Indonesian experience. As you know, the story of the world pandemic disease is from the first happened in Roman Empire, 6th century. This is a plague disease. And the next is pest or Black Death, 1347 in Europe. And the next come chickenpox outbreak in America, 1492. Then come Spanish swine flu, 1918 in Spain. And then SARS in Guangdong, China, 2003. And then endemic MERS in Middle East, respiratory syndrome disease. And then come avian flu in America, 2013. And then the last is COVID-19. It's origin from Wuhan. And this is the world situation that I just mentioned for you. 2000 in the last 16 years, we faced the problem with swine flu here in the, what's that? No, this swine flu, 2009, and then come to 2013, avian flu in America, and then MERS, 2012, and then come again SARS, 2002, and then the last is COVID-19. COVID-19 first occurred in December 2019 in Wuhan, Hubei, China. And WHO announced that COVID-19 is a pandemic disease. 13 April 2020. Then the first case of COVID-19 in Indonesia announced on March 2, 2020. And this next slide. This is 10 countries with the highest number of COVID-19 cases. Of course, number one is United States and Brazil. Then the third is India and Russia. Then come Peru, and then Chile, and then Mexico, and United Kingdom, South Africa, and Iran. The Indonesian is number 26, and the death rate is around 4.7%. When compared to the world cases, death rate is 4.3. And this is the profile of the 10 countries. Hello, it's clear?
Yep. Yeah, clear.
Most medical staff, 19 death cases, yes. Indonesian is number 9 and 2.4% death rate. Next slide. Okay. Why this is slide, yes. Medical workers infected in Indonesia because of the handling system of the COVID. It's not strictly separately facility infrastructure problems because we are a big country. New patient, COVID and non-COVID is not well screened. Screening is not using real-time PCR. Lack of facilities, and is indiscipline to use this one, and less available of PPE. Medical workers lack of education and further supervision, and the patient are not disciplined in using PPE. We must thank for the 11 spine surgeon. They have discussed about the new normal area come after the COVID-19 pandemic. For example, this Dr. Kim from San Diego said that COVID-19 crisis is devastating, is terrible. And Professor Richard from Washington, D.C., he said that we are in an uncharted territory and we will not return to the old normal. And the other, Dr. Andrew from New York City, Mount Sinai Hospital, said that will be less outpatient and surgical volume until there is a vaccine, truly effective drug or herd immunity. And the last statement is from Dr. Scott from Atlanta. In reality, we need proper personal protective equipment. It's clear, yes. And screening, hand hygiene, enable and all healthcare facilities to remain COVID-19 safe. This is the 3 level of the PPE. Level 1 in the left side, but this is modification in our hospital, Port Health Center Hospital. They use also respiratory mask equipment. And then the level 2 PPE, like this one in the central, and level 3 in the right sides. This is in polyclinic and emergency room patient examination for general surgery patients. We cancel to meet your general surgeons unless when the patient has a severe abdominal pain with mass, constipation, patient unable to urinate, and bloody stool, foreign body, wound with massive hemorrhage, mass with pain and redness. And actually, I'm a cardio and thoracic and vascular surgeon. Of course, we have also the protocol from our national organization. Cancel to meet your cardiothoracic and vascular surgeon unless disturbance in your hemodialysis access, thoracic and vascular trauma with massive hemorrhage, severe pain in upper or lower extremity, and ischemic cyanosis, acute chest pain, of course, need immediately for surgery, might be CABG or PCA, BCA, PCI, wound and with fever and septic symptoms, severe pain, swelling on the lower extremity with warm temperature, severe pain and pulsatile mass in abdominal area, and severe shortness breath after trauma. And of course, these emergency surgical cases that we must direct treat the patient. Trauma on the neck, head, spine, thorax area, abdominal, extremity, and inhalation, especially inhalation for the gas inhalation or chemical inhalation. Severe bleeding like trauma in the our brain, epidural hematome, and so on. Venous peritoneum on the thorax area, abdominal, extremity, or vascular problem, infection like abscess, the thoracic cavity or abdominal cavity, obstruction or airway and vascular and gastrointestinal tract, burn injury or drowning. This is my case. This happened before the pandemic era. This is, for example, this emergency surgery case. This man, 40 years old, and has a stab wound on the chest, and the knife go into the chest cavity in the left side, and then goes through the abdominal cavity, injured the lower lobe of the lung in the left, and then also injured the edge of the right ventricle wall, and then went through diaphragm and then injured the liver. That's why we open on not only the chest, and we open also the abdominal. This is the knife in the left side, and this is the patient after the operation. Next slide is here. There's another. This happened in the last month. I treat this patient urgent surgery because he has a shortness of the breath caused by constrictive pericarditis. But after then we prepare the patient, it's clear it's a non-COVID patient. That's why we plan the surgery, and you look in the left side, it is clear in the CT scan, so that's thickening of the pericardial sac. And then this is the surgery situation. We excise the thickening of the pericardial sac. This appeal of severe calcified constrictive pericarditis. And this is the team in the left side. This we use the level 2 PPE. The right side is the pericardial peel. Next slide is here. This is the procedure and action that's we must use PPI level 2. The patient is 40 years old, 45 years old actually, a man. Shortness of the breath because of the massive pleural effusion on the right side, and I insert the chest tubes. And the patient getting better and survive. Slide, please. This is our hospital, one in Port Health Hospital, and the other is Adiusada Private Hospital. We have two ways for corona patient route and then non-corona patient route. Separately. Next, please. This is from the front of our hospital, the private Adiusada Hospital. In the last month, during the June 2020, we have 71 COVID-19 patients hospitalized and treated, good results. The death case is only 2 patients, 2.8%. The left side, the first screening by the officials, and then this is they screen the thermogun for the patient, and this is our emergency room. Next slide, this one. Surgery guideline in the patient with COVID-19. We ask the patient identification of the patient, the name, age, and so on. And then the screening in the department of triage. And then the history of fever, last 14 days, respiratory disorder, anorexia, myalgia, and then comorbid history lung, hearts, or diabetic patient, kidney patient, malignancy, pregnant patient, and so on. Contact with COVID-19 in the last 14 days. Physical examination when the patient fever over than 38 degree, respiratory disorders, and oxygen saturation under than 90%. And laboratory and radiology examination, especially CT scan. Next slide, Cesar. Why we use the first examination, CT scan examination, and I want to explain you next slides. Just here, we have this is the protocol with scoring system. When is there pneumonia, and we note the score 5, and then contact history with COVID-19 positive patient, also 5, score is 5, and the patient have fever in the past 14 days, it is 3, and desaturation of the oxygen saturation under than actually 90%. And about the ages, it's more over than 44-year-olds, and the gender, male, with the point is 1, and then the other is 1. And also our blood examination, neutrophil lymphocyte ratio, when over than 3.13 is not 1 score. When the patient, this emergency, with total score more than 10, and we must perform this patient with PPE level 3. We suspect this COVID patient. This next slide, this compare between chest X-ray and CT scan. In that hospital, we prefer direct examine the lung or the thorax with the CT scan, because the sensitivity and specificity is more better. 83% for sensitivity and specificity 94%. When with chest X-ray, the specificity only 66% and the sensitivity only 77%. This look in this CT scan is ground glass opacity. And this is our protocol. Of course, I have told you that's the patient screening in the emergency room. We separate, this is elective or emergency patient. High priority, directly we prepare for surgery. And of course, we have a special operating room and negative with the negative pressure. And we use a level 3 PPE. And after the surgery, should be the patient put in the isolated ICU room and treated by the COVID team. This is another example how to manage COVID patient, maybe for the next time when we have a good radiology technology advances. Like we have no this one, MSCT 640 and 4 dimension of CT scan, but maybe next 6 months we have this equipment. And you look this patient, problem with multi-trauma patient, maybe with this equipment, radiology technology advances, we can detect all the anomaly of this patient, multi-trauma, within 10 minutes. This is one of the advantages of the technology. Next, normal, new normal, and in surgery. The new order of life to adapt the COVID-19. Are you ready for this new normal surgery? We cannot predict when this pandemic over. How about the WHO guideline? Because we face the totally changes of our behavior. Then changes all our living style. Is your institution and society prepared for this the new normal? And it is a great uncertainty and more rapid changes than ever before in our lifetime. It's clear that COVID-19 has brought about the huge changes in society, consumers, and businesses, including in medicine. At the same time, we face the area that's called the fourth industrial revolution as we move rapidly into the digital era. This is the new normal in surgery. This might be happen in the next year or the beginning of the next year, 2021 or more longer than that. And this is for Professor George Solfas and Max. How are you, Max?
I'm fine. Thank you. It was a wonderful lecture.
Remember these photos? in 2000.
I do. I do
Yeah,
remember.
2017 in Taiwan, Kaohsiung. Yes.
Yes.
And in the right, this is Professor Sulfas and Professor Sunario, is also from Indonesia. And Professor Sulfas in the right side and above as the instead as a president of the ICS Global. Okay, I think this on. This is also, you remember this 2017, no, 2016 in Kyoto, Japan. Yeah.
Yes.
Oh, you look handsome, yeah, Professor Mr. Max.
Thank you. Thank you.
Okay. And last but not least, thank you very much. This is our new campus because 2 years ago, I retired from the medical school at Langga University and moved to the private medical school, Widya Mandala Katolik University. Stay safe and stay healthy. Okay, that's all.
Thank you very much, Prof. Paul Tolili, for your presentation. And now we come to the discussion session. I will tell the audience that we skip the discussion for Professor Sulfas because he has to go to the operation room for another surgery. So the question or the discussion is for the other two speakers, Professor Paul Tahalili and Professor Samsu Budiono. Is there any direct question? You can raise your hand and make a sign that I can see you and to give you the opportunity to ask direct question. While waiting for the question, I would like to ask a question to Max Downham regarding to this COVID-19 pandemic. I guess that there are many programs of the International College of Surgeons will be postponed, including the World Congress, the next World Congress that actually should be held in Thailand this year. Maybe you have short explanation about this. Thank you, Max.
Yes. Thank you, Dr. Manopo. Yes, the the 42nd International College of Surgeons World Congress that was to be held in early November 2020 this year has been, by decision of the International Executive Council, deferred until November 17-19 of 2021. So and that will include the business meetings on November 15 and 16, including the election of officers to the International College of Surgeons. So we have, in summary, deferred the meeting of the World Congress, 42nd World Congress, to Bangkok, Thailand, to November 17-19, 2021. And so I think in terms of the other meetings, a number of meetings, Dr. Manopo, have been deferred, either permanent or deferred or canceled, with the next meeting then coming probably in most cases 2021. So thank you.
Thank you very much, Mr. Max Downham, for your explanation. Is there any question from the floor for the speakers or for other information like the brief survey of Dr. Franz Arifin and maybe to Mr. Max Downham? Okay, while waiting for the question, I would like to ask question. Okay, yeah. Yes. Prof. Sri Malyawan, yes.
My question addressed to Mr. Mac. Do you have any suggestion how to, education for medical practitioner? We in hospital, mostly before COVID era, no problem with this. Now, do you have suggestion how to teach the medical student efficiently? Thank you.
Max, do you catch the point of the question from Prof. Sri Maliawan?
Yes, I think I caught it,
Okay.
and if I'm happy to try to respond as best I can, and certainly the first response I would give you really emanates, Dr. Maliwan, from the the founder of the college, Dr. Max Thorak, who said, amongst other very wise matters, that in the process of the International College of Surgeons missions, everyone is both a student and a teacher, and at the same time. I think one of the values of the college is to have a number of people serve as teachers, and in the process of teaching, I think they learn a great deal. And so the suggestions to you, Dr. Maliwan, it's from me, is that there may be better answers, but is the specialty surgery webinar program that I mentioned a few minutes ago that will launch in September of this year on a worldwide basis. It will be quite an undertaking and a very exciting undertaking. And I think in those programs, Dr. Maliwan, that obviously the COVID-19 impacts and the World Health Organization guidelines, of which we are publishing on our website, the icsglobal.org, will be important and will be included in those discussions. From my perspective, the COVID-19 situation evolves on a day-by-day basis, week by week, month by month. It seems that we have some new information quite frequently that we didn't know before, or perhaps knew, but in a different perspective. So I believe in those webinar programs, Dr. Maliwan, that the answer to your question, at least for me, is the students and the people who are presenting the webinars will outline that. In terms of students, if I may just focus a moment on that, I think the International College of Surgeons presents an absolutely wonderful opportunity for students to participate not only in the webinars, but in the global humanitarian surgery programs. In the programs that the college is running, everyone, young people, students, more experienced people, all have the opportunity to do what Max Thorak said, which is to be a teacher and a student at the same time. And in the process, I think learning, communications, leadership, all of those qualities evolve. So that's my answer. Thank you.
Thank you, Mr. Max Downham. Professor Sri Maliawan, is your questions answered?
I want to ask. I want to ask.
Knowledge, for knowledge is no problem, but the most problem is a little bit difficult. Psychomotor, how to enhance his experience about psychomotor. It's hard to evaluate it. Thank you. Anyway, it's good.
Okay, I have a question. I have an answer for Professor Sri Maliawan.
Yeah, please, Professor Paul.
It's allowed. Okay, good. As a dean of medical school, until now, our campus is still closed. But we prepare for the first step of the medical school that's called preclinic phase time. We start on September 7, September 7, yes, okay. All the lecture with online, and all the skills lab and practicum also online. This is our commitment to give knowledge for the medical school, pre-clinic base. And for the clinic co-assistant, it's depend on the hospital, but we have predict maybe it's we postpone until the beginning of the next year. Depend on the development of the pandemic of COVID-19. That's our policy.
Okay, thank you, Professor Paul Tahalili, for the explanation. Any other question from the floor? We can receive one question more because the time is approaching to 9 p.m. Any question from the floor, please? Okay, if there's no question, I will ask a question to Professor Samsu Budiono. For the humanitarian action of the ophthalmic surgery with the mobile unit that go to the villages or to the health center, what did they use for the techniques to cataract surgery in mobile units to the villages or health center? Is it the same like you have explained on your slides, or it's conventional techniques? Thank you, Professor Samsu.
Okay, thank you. Okay, thank you. We have a mobile eye unit in our faculty, and but it's called social. What is that? Social for social. This is like a charity, okay?
Yes.
Into the health center. So many in every province we have a organization for. This is not mobile unit again. It's called yeah, that's a charity, I think. Yeah, okay. We use pico-emulsification, especially of one if there is a difficulty, if there is iritis because of infection and so on, maybe the other technique we use, but mostly pico-emulsification, not laser, of course, because it's I think the machine is too expensive, I think. Yeah, thank you.
Okay, thank you very much, Professor Samsu Budiono. So we have reached to the end of this surgical forum. And for the closing remark, I would like to invite Mr. Max Downham and Professor Simaliawan to deliver the closing speech. First, from Mr. Max Downham. The floor is yours.
Oh, thank you, Dr. Manopo. And first of all, thanks to Professor Tahalehi, Dr. Franz Ahrens, Professor Hendarti, the other speakers. And I think all of you in the Indonesian ICS section, as Professor Sufas earlier indicated, are to be commended for conducting these webinar sessions, and most importantly, for the example that you are providing to other ICS sections around the world. I think it is wonderful what you're doing. You're doing it with sincere commitment, and I think to further and help patients in terms of how you work together. I think that I know Dr. Arifins mentioned advocacy, and several times throughout the sessions, students, teachers, and I think also working together on a collaborative interdisciplinary basis, as Professor Sufas indicated, and certainly Professor Tahalehi, as you indicated in your lecture, the screening for COVID-19 patients and the impact on the subsequent procedures that you do in the surgeries is very, very important. So I think it's been very practical information, as Dr. Arifins indicated. It's very knowledgeable. It's practical knowledge, very helpful. I think I noted in the screen about 175 people were generally on the webinar. I think that's fantastic. So I congratulate all of you, the leaders and all fellows in the Indonesian section and all other people who participated from other areas outside of Indonesia. Thank you so very much. And Dr. Manopo, thank you for your good work in terms of serving as moderator. Thank you.
Thank you very much, Mr. Max Dunham, for your support to our surgical forum. And next, I would like to invite Professor Sri Maliawan to deliver your closing notes. The floor is yours.
Thank you, Dr. Peter Manopo. Thank you for the opportunity. Good evening, Professor and all participants. Thank you for participating in this webinar of ICS Indonesian section. The title is Adapted Surgery in New Normal Era. We have here 4 speakers. The first speaker from Surabaya, Dr. Franz. He is talking a very good brief research of COVID-19 or impact of COVID-19 for human being. The first one is, I highlight here is less patient who come to the hospital, not less patient at all, because the patient priority is emergency patient. The brief survey, very good idea and very informative. And the second speaker is Professor Surfas. He is talking about adapting sophisticated technology to hepatobiliary surgery. Thank you for very good, interesting, and very informative. I will not summarize it because it's already clear, very clear and good explanation. The speaker is Prof. Samsu. He is talking about cataract refractive surgery. Very excellent talk. Thank you, Professor Samsu. And the last one is Professor Paul. He is talking about strategy in manage the patient in new era.
Your voice is not clear, Prof. Sri Maliawan. Hello, Prof. Sri Maliawan. Prof. Sri Maliawan.
Hello?
Yeah, you can proceed, yeah.
Okay. The most important thing is how to protect yourself, avoid from COVID-19. We are now belong to the group of vulnerable. We are belong to vulnerable group to contact with COVID-19. Older adults and people who have severe underlying medical condition like heart or lung disease or diabetes seem to be a higher risk for developing serious complications from COVID-19. The best way to prevent illness is to avoid being exposed to this virus. This virus is thought to spread mainly from person to person. So, for medical practitioner or for surgeon, for example, most important one is please obey the protocol published by WHO. Everyone should obey the rule. Wash your hand often with soap. If there is no soap, hand sanitizer. Avoid refreshing. Avoid touching your eyes, nose, and mouth with unwashed hand. So take care of yourself and stay safe. That is the most important thing, not only the patient. You have to save yourself also and keep away from virus. I mean from virus, not from the patient. And the last but not least, thank you for all of the speakers. Thank you for Mr. Mac, Prof. Paul, Prof. Samsu, Prof. Sulpas, and Dr. Franz, and all participants. Thank you. Good evening. Now, I let Dr. Peter Manopo to take your time now. Okay.
Yeah, thank you very much, Professor Sri Malyawan, for your closing speech. And now I would like to, on behalf of the International College of Surgeons Indonesia section, I would like to express my gratitude for all the participants, particularly for our guest speakers, Professor Sulfas, Mr. Max Downham, and also Professor Paul Tahleli, Professor Samsu Budiono, Professor Sri Malyawan, Professor Hendy Hendarto, Dr. Franz Arifin, and the IT team, Mr. Bimo Kumlar, Ms. Dewi, and the Alumni Association of the School of Medicine and the School of Medicine of Widya Mandala Katolik University in Surabaya, and the Indonesian Association of Cardiothoracic and Vascular Surgeons, and again for all participants. We will meet for the next chapter on the second Friday, the same time, because this time 7 p.m. is comfort for our colleagues in the United States and also in Europe. But in Indonesia, maybe, yeah, I think it's tolerable, yeah, acceptable to do it from 7 until 9 p.m. Again, thank you very much. Stay healthy, and we will meet again next month. Thank you.
Thank you, Max.
Thank
From
you.
Paul. Thank you.
Thank you, Professor Tahleli.
Very much. Thank
Yes.
you.
Thank
Thank you.
you.
Thank you, Peter.
Your
Yeah,
you.
thank you.
Manopo.
Yeah.
Yes.
Yeah. Okay.
Thank
See
you
you
for all
again.
participants, all speakers, and all committee. You are appreciate your work, and this seminar is well going success. Thank you once again.
Oh, yeah. One thing for all our participants who would like to have the certificate, this surgical forum is CMA accredited by the Indonesian Medical Association, ED. So you can send email and then we will send you the certificate. Thank you very much. Goodbye,
Bye-bye.
everyone.
Thank you.
Bye-bye.
Goodbye. Thank you. Bye.
Bye-bye, Max.
Thank you very
Bye.
much.
Thank you.
Thank you.
Selamat malam, Prof. Paul.
Oh iya, selamat malam. Li. Aduh, kita belum ketemu lagi.
Suaranya. Terima kasih, selamat malam.
Ya, kapan-kapan kembali lagi.
Ya.
Terima kasih. Terima kasih semuanya. Saya live ya. Thank you.